I'll post all of these after the lesson 6. So if you like the questions and the cases, they'll all be posted shortly. Just in one final single PowerPoint site. Okay, and PDF. All right, which of the following is the main secretory product of the thyroid gland? So which hormone is released from the actual one? Don't say E, okay? No, it's just 2 days off, but yeah, what do we think?
2 days off.
C, okay, thanks. Okay, good job. T4, right? T4 is converted into the active form T3, typically in the target organs, but it is around. T3 is around, and some T3 is produced in the thyroid gland, especially in what disease? Graves, right? Graves, where it's hyperactive, that autoimmune receptor triggered activity. Here's the reasons why. TRH, just in the same releasing hormones as hypothalamus. TSH is pituitary. T3 I talked about, and you guys don't feel bad. What test is Friday?
Cardio.
Okay. And then that's the one. Okay. You good? Yeah. All right. 23-year-old female presents to your clinic complaining of fatigue, bilateral ear pain, pharyngitis, mild dysphagia. Her temperature is 101 degrees Fahrenheit. And her remaining vital signs are within normal limits. Labs include low TSH, elevated free T4, and an elevated ESR. Which of the following is correct regarding the underlying etiology for this suspected condition? So not what's the diagnosis, but what is pathophys or the, precipitating, it's kind of a mix of options down there. Associated with a viral infection, we should expect erythema and fluctuance of the thyroid, occurs more often in males, fibrous infiltration of the thyroid, or associated with autoimmune etiology. I see A. Perfect. Good job. So it's the virus. And then in this history, there's pain, fatigue, with that radiating pain, pharyngitis, the elevated ESR. She in a hypo or hyper state. Hyper, right? Usually it's going to be mild. But yeah, it's from that passive release of T4 and T3 that causes that variable hyperthyroid state. This is a slide. There's a little virus in the corner. And then just one. Okay. And then why it's not B, that's going to be that infectious suppurative, right? That's that red bacterial causing. It can be caused by parasites and other things, but not non-viral causing. They're a lot sicker, right? They're being admitted. We know real thyroid condition is higher in males. We get concerned when males have nodules, especially young males, right, for cancer. But it's females pretty much across the board for thyroid stuff. But again, you'll diagnose males with hypothyroidism. My first goiter as a brand new PA was in a male. You could see it when I walked in. Anyway, fibrous inflammation, that's that old female, elderly female, we'll go with that word, patient, and it's really it's uncomfortable because it causes scar tissue, and it's a really hard thyroid on exam. And then there's your autoimmune conditions. And technically, you could have Hashimoto's and have a cold at the same time, but again, I won't do that to you. All right. Which of the following is the most common etiology for primary hypothyroidism globally? Yeah, diversification, viral, iodine deficiency, autoimmune, thyroiditis, or strep. C, yes, very good. Not here, but it still exists, like, forget, 1.8 billion or something. Globally, what's the most common cause in the United States? Hashimoto's, right? And that's for adults and kids. And we can talk about each one of these already. The strep one and the fibrous, the Rydell's, IgG4 are less common. And the autoimmune. A 36-year-old female presents with signs and symptoms concerning for hypothyroidism. Which of the following lab tests are indicated, which of the following lab tests indicate the diagnosis of primary hypothyroidism, right? Most common in what we're going to see. Primary tells me where's the problem. And the actual gland, right? So the failure of function, it's going to be hypofunction, it's hypothyroidism, is in the gland itself, not the pituitary or the hypothalamus. C. Like C? I like C too. Good. Good job. Remember that high T4 and low TSH because pituitary is working appropriately. When T4 goes up, it should cut back on TSH. Or, I said that wrong. Sorry. When the gland is not working, I wanted to rephrase that. We have low free T4, and so the pituitary responds appropriately by increasing TSH. And then here's your justification. A 52-year-old woman presents to your office for a follow-up on her newly diagnosed hypothyroidism. 8 weeks ago, you prescribed levothyroxine. Good job. And at that time, her TSH was found to be elevated. She has been taking her medications as instructed, and her symptoms are somewhat better. But retesting of her TSH shows that it is still high. Which of the following is the next best step in her management? All right, so now it's the plan part. You're the PA who has to make these clinical decision-making. You guys got this, all right? So we can change her medication to our armor thyroid, right, our pink thyroid that I love so much. We can decrease her levothyroxine, and then repeat labs in 8 weeks. Increase her levothyroxine, repeat labs in 8 weeks. Maintain the current dose, see her back with that 8-week lab check, or change the medication to methimazole and repeat labs.
Alex.
I heard C. Thank you. All right, perfect, right? So her TSH is still high. What should we do before we even touch the medication? What should we ask her? Yeah, are you remembering it every day? Are you taking it in the morning on an empty stomach, 30 to 60 minutes before a meal? Are you taking it with your vitamins? Are you taking it with your Frappuccino yumminess that can interact and block the function of TSH? Have you guys seen that do you guys know what House is? TV show? So there's they probably used it in your poem lecture, but there's a woman who comes in and she's complaining her albuterol isn't working. And he responded like, show me how you're using it. And she goes, yeah, so, yeah. But I will tell you that's accurate, but most of the time they just, it's not as obnoxious, but yeah, they just again, ask the question, show me how. One more. Which of the following sign or symptom is seen in hyperthyroidism? Hyper, so that metabolic knob, energy knob, temperature knob is turning too high. Great. E, tachycardia, right? So patient, real quick, these ones are all, the top four are usually more consistent with hypo, right? That all tracks. And you know when someone, if they're over-treated on their meds, a hypo patient can turn hyper, right? Okay. All right, 15-year-old female presents for a follow-up exam. She's recently diagnosed with a thyroid nodule with lymphadenopathy noted during her wellness exam 3 weeks ago. Okay, this is our patient from last week, the one who had the radiation for tonsillars or something, tonsillitis, or I can't remember. The thyroid ultrasound, so you did labs on her, you ordered an ultrasound, and here's your results. It reveals a 1.4 centimeter complex cyst. She has the history of neck radiation, and then we have our FNA biopsy back, right? It confirms abnormal cells. Which of the following is the most common type of thyroid cancer? Yeah, A, papillary. It's the least aggressive. How do we treat all of these? Yeah, we were going to remove it, right? Surgery, it's cancer. Now, obviously, some patients might have their own, you have the option for a plus or minus ablation for the top two because they absorb iodine. But yeah, surgical is a treatment for all. So, and she's the most common. She has a history of radiation. Okay. Most of the almost done with the test. Majority of the questions, I'll kind of give you the percentages when we do the review, are from that thyroid lecture because it's the biggest and it's really what you're going to see most. All right, switching gears to adrenal cortex. So a few different hormones. We're going to talk about, we're going to come back to Cushing's. We're going to introduce what happens when cortisol is too low. So that's adrenal insufficiency. And of course, there's primary and secondary, right? And then we're going to talk about hyperaldosteronism. Have you talked about that in cards yet? With secondary hypertension a little bit through the rest. And then we may get to the last one, or we might just do the last one next time we meet, which is congenital adrenal hyperplasia. It's interesting. All right, so we have our first patient in the morning. I can't see, my laptop's too small. Okay, so sick, not sick? Stable, right? Well, maybe sick, she looks down, but stable, right? She's maybe not bleeding or around. Okay, so acutely ill, she's okay. She's a 38-year-old female. She's complaining of difficulty losing weight. She stated she's been working to lose weight for 3 months, but instead she's gained 20 pounds. She reports feeling fatigue and having difficulty sleeping. Here's her vitals. What do you think about those vitals? Yeah, the blood pressure is too high, 159 over 92. BMI, so that's she meets criteria for obesity. What about that last menstrual period? Is that normal for women to go 8 weeks? And you guys haven't had women's health. No, typically it's like 28 to 36 days, so her menstrual cycle is a little abnormal. Physical exam, rounded appearance of her face. Do you guys agree? But that could just come with weight gain, right? Notable terminal hairs on her upper lip and chin. So that's like male pattern hair growth in hirsutism, which we'll talk about next block. And it's just because of excess androgens. And abdominal exam, truncal obesity. Okay, purple striae. You know what that is. Extremities show various spots of ecchymosis and various stages on her extremities. All right, what hormone do you think is at excess?
Cortisol.
Cortisol. Who remembers, this is kind of neat, who remembers what labs you check if you are worried about, like, what labs do you want to go to? You have to have 2 out of the 3 positive.
Dexamethasone.
Dexamethasone suppression test.
Saliva.
Yes, 24-hour urine. And then if you're in a clinic that does the 24-hour overnight salivary test, where they have to do the swabs at night. Great job. Okay, so you diagnose her. We don't know if it's Cushing's syndrome, Cushing disease, but you treat her and look, 6 months. You catch. You don't just say, sorry, you need to do X. You do tell her about lifestyle stuff, but you, based on your labs, the dexamethasone suppression test and the 24-hour urine are positive, then you do an ACTH. It points to Cushing disease. So she has a adenoma causing excess ACTH, and she gets the surgical treatment, right? So this is kind of a review, bringing lesson 3 back into this lesson. She's lost weight, obviously has the same stretch marks. Her blood pressure looks much better. Her BMI is starting to go down. Great job, PAs. Students. Okay, you guys got that. All right, so let's go a little quick. My anatomy reviews are very quick because you guys have already had this. But again, who remembers the adrenals, right? There's a cortex, there's a medulla, there's our zona follicularis, reticula there. And so we're going to focus on the cortex today. And there's multiple hormones. So cortisol we're going to talk about a lot. Androgens, tiny bit. And then aldosterone at the top. So cortisol is regulated by what? The ACTH from the pituitary, right? Aldosterone is also regulated by ACTH, but primarily by the renin-angiotensin-aldosterone system, which we'll talk about soon. Okay. So I don't know, I like this slide. It's that so this is your stress feedback loop, okay? And so we're gonna do the one on the right today, the one on the left tomorrow. But again, your body needs cortisol for some reason. Maybe there's an infection, there's stress, exercise, and so CRH and ACTH are released, right? So from the anterior pituitary, ACTH goes through the bloodstream to the primary gland, which is the adrenals, and we release cortisol. Also, we can release aldosterone too, depending on what's going on stress-wise. Okay. So this is just like a breakdown of the hormones that happen in the adrenals. So again, we know cortisol, aldosterone, got it. DHEAS, or dihydroepiandrosterone, mimics ACTH. When ACTH goes up, usually DHEAS goes up. But that was more FYI-ish. We'll talk about it a little bit, and then we'll talk about these soon. And then the medulla is lesson 6, so just a hormone review. We got this down, right? This is just a review from what I've been saying. Just more of a simplistic picture of our feedback. If this doesn't click, let me know. I'll have you come teach it to me so that it does start to click, okay? All right. CRH, so again, it's in the name, corticotropin releasing hormone, says this is coming from the hypothalamus, right? And it is released in response of low cortisol, and then it activates that anterior pituitary, the ACTH. Secretion increased in stressful events. So if you have a cold, if you have a surgery, some kind of injury like a car accident, right? You're stressed and you may be injured. We're going to release that. Exercise. When you go hypoglycemic, because of the cortisol's impact on carbohydrate metabolism, protein metabolism, and all that, when your blood glucose goes low, cortisol is increased. And then obviously starvation will be stress for all the reasons, right? Hypoglycemia and stress. But what I care most about is your ACTH. So again, it's anterior pituitary. Secreted pulses in a diurnal rhythm. What does diurnal mean? So it's probably has to do with time of day, right? Right. So essentially, what happens is at night cortisol dips down, and in the morning it goes up. Okay. So diurnal. So it's lower in the evening, and then it goes up. There's going to be other causes, right? So stress, exercise, things that make it go up and down. But typically, it's diurnal pattern. Those of you who have kids, if you have little kids, you remember when they have like a fever or they're sick, they're doing fine during the day, but then for whatever reason that fever is harder to control at night. Or all of us as adults, we kind of get worse at night. So you can there's multiple hormones, but cortisol plays a role, right? Okay, so if my cortisol is good and then it dips, why am I feeling worse at night as it dips? Because that so the cortisol suppresses the immune system. So immune system suppressed, cortisol dips, immune system gets kind of party, right? And so then that's why the fever is harder to control or the fever spikes. There's other hormones at play too, but again, the cortisol diurnal pattern is why we usually feel sicker or worse in the evening. And then in the morning, cortisol comes up, we get that immune suppression, and we start to potentially think we're okay to go to school and work and stuff. All right, so when it's released, it goes down to the adrenals and it tells them to release hormones. Okay, it also stimulates the melanocytes, so that's the, typically in Addison's, when ACTH is really high, that's why you'll see the hyperpigmentation in those people. Okay. Cortisol, it's the main hormone out of the adrenals, is what we've been talking about, right? Diurnal pattern. Why is it a diurnal pattern? Because it follows ACTH. ACTH is diurnal, cortisol is diurnal. Okay. So highest in the morning, lower right before bed. And then we have other factors that increase it. So this is just a range. So the upper range is in green, blue range is in low, and again, it's peaked in the morning. And that's a nice, pretty simple chart, but this is real life, right? Okay, so where are we at? So breakfast, you guys right here, your cortisol, ACTH are high. And then throughout the day, maybe you're eating, maybe you've exercised in here, there's some stress. Someone brought up that farm test. And then as you go to sleep, both go down. Okay? So red is ACTH and green is cortisol. Questions on the diurnal pattern? That makes sense. Which hormone release is strictly pulsatile? Yes, somatotrophic. So that's the growth hormone. Growth hormone, right? That's the pulsatile one. And this one isn't technically pulses, but it's in that diurnal pattern. Okay. This just shows the metabolic effects I alluded to, right? So it plays a role in gluconeogenesis. What do you think if cortisol, essentially cortisol, if it's high for a long period of time, it increases blood glucose. So what are people with Cushing's at risk for? Diabetes, right? Goes along with that. Plus they have the obesity and all of the other things. Again, I don't really ask questions on this. This is important as far as what it's doing in the body, not just the stress, like the immunosuppression and things like that. Okay, so normal versus excess, right? So excess, we need cortisol. It's important, but when it's in excess, it can cause problems, right? So inflammation is suppressed. So we use that, right? When we give someone oral glucocorticoids, what happens? It's all over anti-inflammatory, right? Remember our thyroiditis patient for the viral cause. First we give them NSAIDs. If that doesn't work, we give them corticosteroids, right? We're decreasing all over inflammation. But if we do that all the time, you see that would be a problem? We want to do that all the time. Same with immune system suppression, right? We're going to suppress the immune system in somebody who has like a heart transplant or some lung transplant or some kind of transplant. We want to calm down the immune system. But if I suppress the immune system too much, what am I at risk of? Infections, right? Lots of things. So it impacts the bone, right? Our bone density and decreases calcium absorption. So what are these Cushing's patients or anybody who has excess cortisol at risk for? Osteoporosis. So usually we think of osteoporosis as that little lady, but this could be anybody with Cushing's disease has a risk for osteoporosis. And so that whether they have Cushing's or they're taking excess cortisol for whatever condition. And then obviously truncal obesity or truncal obesity, weight gain, which goes into our classic Cushing's central obesity patient. Also, so it affects the bone, like we talked about, but connective tissue and muscle. So this is why they'll lose elasticity in their skin. They have the ecchymosis, right? Easy bruising, the striae. So that's why we see these skin changes in our Cushing patients who have prolonged excess cortisol, right? Impaired with healing. It's a big one too. They'll retain water. Sure. Growth failure in children. I don't talk about excess cortisol in kids, but there you go. And then they definitely will have mood changes, right? If cortisol is high for a really long time, they can have mood changes just from the hormones alone, and then you add all the other things they're doing, right? So we're going to go into Cushing syndrome or hypercortisolism. Any questions? Anatomy review or what's going on? So this is the most annoying nomenclature in Endo, I think, because we have Cushing syndrome, remember, is the umbrella of both Cushing disease and Cushing syndrome. What? So again, a lot of times we'll use that ACTH dependent, telling me the high cortisol is due to excess ACTH, and then ACT independent. And that's what we're going to talk about more today. We'll review both. You won't know where the cause is initially because they present the exact same. So all you're going to be like, oh, I think this person has excess cortisol. I'm going to do labs to confirm that. Then I'm going to do more labs to confirm where the problem is. Okay. So again, we're going to highlight more about the adrenals and the ACTH independent, but a quick review of both. Okay. So exogenous long-term steroid glucocorticoids. This is really, really common. We are causing this, whether it's medications. Sometimes there's even some supplements out there that secretly have corticosteroids in them. Asthma patients we give steroids to, right? Anybody with like a rheumatoid condition, lupus, rheumatoid arthritis, we use it for that anti-inflammatory piece. Transplant patients, right? We're using that for the immunosuppression piece. So again, we need steroids a lot, but we know now that we need to avoid being on them long term because we can cause Cushing's syndrome. And then you have your endogenous causes, right? ACTH dependent. So excess ACTH is being secreted somewhere. We talked about that in lesson 3, and we'll add a little bit more to it today. And then ACTH independent. What that tells me is ACTH is being secreted cortisol is being secreted in excess, not because of ACTH is driving it, because there's an anonymous, it's working outside the feedback loop. You have some kind of cause of excess cortisol from the adrenals. All right, so ACTH dependent, dome, right? Adenoma in the dome. So 90% of the time that's going to be where? Pituitary, right? 90% of the time. Where's the problem? The pituitary. If you do an MRI and it's normal, then you're going to look for an ectopic source. Now, that ectopic cancer source can be anywhere in the body, but most likely it's going to be in the lungs. So keep it simple. So if does that make sense? Why maybe if the MRI is normal, I might do a CT scan looking for that ectopic course. So 10% of the time it's cancer, but most of the time it's that adenoma that we learned about. Now, ACTH independent, autonomous cortisol production from the adrenals. So there's either an adenoma that is driving excess cortisol, or we have hyperplasia. Hyperplasia, remember, that's the enlargement or increase in size of the gland. So in this case, that hyperplasia is increasing function. Okay. Well, if you had to guess, what do you think ACTH lab levels are in this scenario? If the problem's in the adrenals, pituitary is working, so ACTH will be low. We'll get there. All right, so again, we know all about the adenomas for Cushing disease, ACTH dependent in the dome, and then here are those ectopic courses, right? They are causes for usually cancer that can just have this tumor that's causing cancer and it's kicking out ACTH. We look at the lungs first, but there are lots of cases. Just like Cushing disease, people with Cushing syndrome or ACTH independent hypercortisolism, it's delayed. It takes a really long time for this to be diagnosed, right? It is a gradual process sometimes, but again, it's like, oh, it's obesity. Maybe they didn't actually do a good physical exam and take their shirt off, or there's something in their history. Maybe they've already been overweight for a long time. Maybe they're focused on the diabetes, the metabolic syndrome, or the hypertension. So just a plug to listen to your patients. Do an actual physical exam. Okay. We know this. I'm not going to go through it one by one, but this is your classic Cushing's patient. And again, it's the same for Cushing syndrome or Cushing disease. They present the exact same. Here's the diagram. Yep. All right. What do you guys notice? What do you see? Yeah, so female, obesity, like maybe, right? What about her skin? Yeah, we see hair growth, some acne, hirsutism, right? So with cortisol, what that tells me is if cortisol is being released in excess, maybe some androgens are being released, causing the acne. Now, she could just have acne, not have anything. She could just be obese, and that's all this. Most of the time, that's what this patient is. But we're in Endo, so. But potentially, you could say that's moon face. Would you call it plethora? You know what plethora is? That redness. I don't know if I see it in that picture per se. But what would we need to do? Get a good history and get a full physical exam. A face alone isn't going to tell me if it's Cushing's. All right. This is Tony. I apologize. I don't know how old he is. So he's coming to see you. He has had fast weight gain. He's tried all these diets and nothing's working. You see these large stretch marks on his abdomen. He's breaking out with acne, which he hasn't done since he was a teenager. But the acne's on his chest and his back. He's having mood swings, so anger outbursts. And then he notices just feeling weakness. His ankle's dislocating a lot. He's getting a lot of bruises, but not from activity. And he even had some rib fractures from doing like this regular day-to-day activity. And the list goes on and on and on. So, what are you thinking? What's on your differential? What's his cortisol? Probably high, right? We're going to do, when we do our workup, our dexamethasone suppression, the 24-hour urine, to confirm if it's hypercortisolism. So his dexamethasone was high, his urine 24-hour was high, so you confirm this person has hypercortisolism, and then you need to do ACTH, all right? And for him, the ACTH was high. It was almost 200. So if ACTH is high and hypercortisolism, what are we thinking? Cushing disease, or so where are we gonna, so Cushing disease, right? Because it's ACTH is driving that high cortisol. So we have both high. So I'm gonna do an MRI, right? This MRI was normal. Crap. Now what do we do? Well, I'll tell you what these people did. The MRI was normal, so they went ahead and they looked, they did an abdominal CT. His adrenals looked fine. No adenoma, no hyperplasia. They added a chest imaging, and they found a tumor. So this was a lung cancer cause. I don't believe he smoked. It's not in the story. But so they found, I think they had to do a PET scan too. So anyway, they found, so his is an example of the ectopic, so the 10%. But look at what happens with treatment. It's pretty awesome. It's but again, I know we see a lot of men, not in the military, but that look like this, but they, his story is a little bit different, right?
Whoa.
Okay, so this is just like a summary from current. So I added it. I think you guys get it, but essentially, Cushing syndrome. What helps me determine if it's Cushing syndrome is the lack of cortisol in a diurnal pattern, right? They're high all the time. They're not doing what everybody else is, where they go low at night and then high in the morning. There's reduced susceptibility to cortisol by dexamethasone, right? So you do the dexamethasone suppression test and it's high. And then you have increased cortisol production rate. That's what current says, if that helps you. I think you guys have already understood all of those points. Okay, so labs, we know this, right? So we need our 3 initial tests. At least 2 of them have to be completed to meet hypercortisolism, right? Not Cushing disease, not Cushing syndrome, just hypercortisolism. That dexamethasone suppression test, right? They take steroid at night, and then we see what happens to their cortisol in the morning. We make them pee in a big jar for a really long time, or we do that late night salivary test, which also tells us what's happening to their cortisol in the morning. So just a quick reminder, what happens when we do dexamethasone suppression in a normal person. So if I give you guys all steroid at 11 o'clock at night, what should your ACTH do?
Oh.
Drop, right? Negative feedback loop. Then if your ACTH drops down, what should your cortisol do? Even though I gave you the steroid, make less. Because I give you that steroid at night, I'm causing this negative feedback loop, so what should your cortisol be in the morning? Low, right? Low is the pathway. But in a Cushing disease or Cushing syndrome patient, instead, what your body should make less cortisol, but it doesn't. It doesn't tell me where the problem is, it just confirms hypercortisolism. So the lab that helps determine and point you in the right direction is ACTH. And this slide is just a summary slide that we had in the first lesson. But again, ACTH is the factor of what points me in the direction. Is it disease? Is it true syndrome? Is it primary adrenal problem, pituitary, or ectopic? So ACTH is that key lab. So our initial labs confirm high cortisol in the blood, hypercortisolism. Now we know we have hypercortisolism, so we need who to blame, and we do that by the plasma ACTH. Is it dependent or independent? DHAS is FYI. I'm not going to put it. Like in a year or 2 from now, I'll be saying we'll do blood test for DHAS, but we're not there. Okay. So, ACTH dependent, right? The dome or the ectopic. We have elevated ACTH, right? ACTH dependent, elevated. We're thinking Cushing disease or ectopic. If ACTH is low, we know that the problem is in the adrenals, right? The pituitary is working appropriately. You get stuck, just draw your little feedback loop. What should ACTH do when cortisol is low? It should go down. It's doing that, but we still have excess cortisol, so we have the problems in the adrenals. This adenoma that's misbehaving, or this hyperplasia that's causing increased secretion of the hormones in the adrenal hyperplasia. Don't worry about adrenal carcinoma. It's super, super rare. Like I'm not going to touch on that because it's like less than 1%. Okay, so here's just like a summary side by side of both, just looking at the labs. Okay, again, ACTH elevation. Most common cause is medication. If they don't have a med history of steroids, then we're leaning more towards the treatments, right? For adrenal cause, the ACTH will be low. Here's a nice picture. If you like drawings, so you have, this is your normal feedback loop. Everything's good. This is your Cushing disease due to adenoma. It's secreting excess ACTH, which causes too much cortisol. This is your ectopic lung cancer, doing the same thing. And this one is your adrenal adenoma, causing excess cortisol. There's this, if you're a flowchart person, I added this, that works for you. Again, I'm not going to read it because I've talked about it a lot, but this kind of, if you're a flowchart person, there you go. This is money. Don't memorize it per se, because again, if you lean on the feedback, you won't have to, and just draw the feedback loop on the test if you get stuck. But this is the summary of both as far as labs and RADs, right? Cushing disease, ACTH is high, it's dependent. We're going to look at the MRI. MRI is normal, crap. Now we're going to look for lung cancer or something else. So we can do a chest CT. And we'll probably get an abdominal one too, why not? For independent, they have lupus and they've been on steroids for a really long time. Or they have asthma and they had a lot of flares. So we're the cause, right? So then we're going to taper that off. If we did labs, ACTH would be low because why is ACTH low in a patient taking steroids?
Cortisol.
Yeah, because it doesn't need to work, right? Yeah, the steroids are red in the blood. The ACTH, the pituitary doesn't differentiate between this is body cortisol or pill cortisol, right? Okay, good. And then if ACTH is low, they don't have a history of intake of steroids, then we're looking at the adrenals. Is it an adenoma? Usually unilateral adenoma or bilateral hyperplasia, causing excess activity, excess cortisol being secreted. All in one slide. Just FYI. All right, we'll get through treatment and then we'll take a break. Okay, so treatment, there's a table, there's slides, there's either one that you like. So if we're going to stick with the table, because it's all on one page, but you have both depending on what you like as far as studying. But we have our cause of hypercortisolism, right? All the ones we've talked about, and then the treatment. So exogenous cortisol, we're going to gradually discontinue. I can't test you that because I put it on the slide appropriately, but we're going to gradually discontinue them, right? Because and you'll see why when we go to deficiency soon. And reduce that dose, right? Taper them off. Adenoma, surgery, right? We're going to do, which time do we use meds for an adenoma over surgery? Prolactin prescription, right? But the other ones, we're going to do our transcontinental surgery, get rid of the adenoma. Ectopic, obviously, those oncologists are going to hopefully resect that or treat that underlying cancer. So that one's going to be a little, probably prognosis is a little worse. And then if it's an adrenal adenoma, we're going to do a surgical resection if we can. If they're safe enough to have surgery, we're going to remove the mass or potentially one of the adrenal glands. But if it's bilateral adrenal hyperplasia, Should we do meds first or surgery? Meds, right? We want to at least try meds first because if it's happening to both and I take out both, then I lost my adrenals completely. So we're going to try medication, and we'll talk about those in just a minute, to decrease, basically inhibit cortisol release. Now, this is important at the bottom. Successfully treated patients, whether I do with surgery, for the either adenoma or I give them on, or tapering off their DED, you might have a cortisol withdrawal syndrome, right? So they were up here and I take that adenoma out, cortisol drops, right? So even though they were suffering with excess cortisol for years, we're gonna have to give them some cortisol for 6 to 36 months, okay? Because it takes a while for this HPA axis to reset. So this is the table just written out. And this is the medication. So again, maybe you have a person with an adrenal adenoma and you want to give them a medication that decreases corticosteroids. You can do that. Or you have a bilateral hyperplasia patient. I just have the one thing underlined, so I don't care that you know all of the medications. Okay. I told you how they work, very generalized. But I don't. It would just be medication, steroidogenesis inhibitor if I asked a question, okay? And then you get the point. The point is to decrease steroid production in the adrenals. Okay. So untreated Cushing's syndrome is going to be real bad, right? Fatal, right? Over time, that excess cortisol, immune suppression, anti-inflammatory, osteoporosis, truncal obesity, high glucose, so diabetes, hypertension, right? All sorts of things. Skin infections, I'm more susceptible to skin infections, so that can get me, right? Sepsis, so we need to treat these people. But the ones that get treated usually do pretty well. Obviously, with the exception of the cancer patients, it's going to be a different level, right? Because there's underlying cancer, they might not do as well as the others. When do we refer? Soon as you get that elevated dexamethasone suppression test. I'm still going to order the ACTH. I'm still going to do the imaging, whether it's MRI or an abdominal CT to look at the adrenals, or you're going to refer them as soon as you get those dexamethasone suppression tests in your urine back high. Okay? That's it for high cortisol. And next we're going to go into adrenal insufficiency, where everything is low, and so we have our famous President JFK who had Addison's, and the picture is of my friend's dogs. And dogs can get Addison's just like diabetes, and cats with their thyroid conditions. It presented like UTI because Addison's, didn't do so well, unfortunately. But again, we'll stick with the humans when we get back in 10 minutes. The route that you have for running, it's like up and down. Good job, I run late. So it's like an intermediate. But then it's like an 800-meter run. It's like up and I'm signing on for it. So I should go Wednesday then. For the month, yes, correct. For the week, what class? It's not bad. Each class is like 1 week.
If I recycle, I stay here.
But I tend to
You know what's funny is
I did then one second, like spring, the fight, and then 800, it was like 800 meters. We did that 7 back to back. No breaks.
You don't drink protein?
I don't like the powder. And then I did legs Friday. Yes. I know. Doesn't have to turn on the heater. My mind.
Yeah. My wife last night made homemade buns. So I got those at home. That's like I'd rather say today than like sort of my cupcake. Yeah. I feel like that kind of nervous. You got really good attention. I feel like frying them with like getting them fried. I don't know about crispy. So if you when you fry it, you get like that crack. Like this is more of like a heavy one. It's living texture. No matter.
The dead one is like everything we already do. Like hypertension, second. What do we do?
Already?
Yes, it's
Damn.
because it's the beginning of the week. No, it's not
I would go back and forth between this one and the one over there. Look next to it and then we're just like somewhere. I mean, other things, at the
Why is it so cold? It's supposed to be summer. It's supposed to be Texas. It's supposed to be summer every day. All year long.
More than anything. South Texas. Good job. I like the
We can go now.
I'm grateful for today. That's why I'm oh, I have a question.
It's about farm. I mean, I have the answer. I haven't studied enough yet. What's the question?
You said he's been offered a new position. That's what he wants. Depends on it.
Yeah. These are the pro bike.
Overall. So for this, no response.
Yeah. So full effect means that like you have your migraine still control. But like let's say you're having a migraine and so you right? So from that, now you're starting to see okay, maybe now down to two, now down to one of them. You're slowly tapering that whole effect back down. The goal is to
Right. But once up to zero, if you want to gradually fever,
yes.
but why? Is that going to bring me back?
Not necessarily. So the reason why you do that, you can taper off your body. So it won't cause, like, we'll call it pushing it. That's typically what happens. So your body back to then
So there should be a point in which I should migraine medication again. Yeah, so I'm saying is I've never heard someone has migraines never heard anything.
well, they
You
try
know
them
what I
off.
mean?
They do try them off. End up
Okay, we'll get started in a couple seconds. My right hand is so cold because I use a shirt. Goldilocks complaining that it's too hot. It's cold. It's cold today though, huh? I always feel it. Alright, so we are switching gears to not enough cortisol. Okay, it might get a little confusing, mainly on the test with this. So I'll try to hit things and then we get confused on the test, just slow down and maybe draw it out. And we'll hit the confusion and tricks with the confusion when we do the review too, just in case. So we'll learn by repetition. Okay, so primary adrenal insufficiency is also known as Addison's. And essentially it's deficient cortisol because the adrenals fail, right? It's in the name. Primary tells me it's going to be not the pituitary, but the adrenals. And the cause of the destruction of the issue and the failure of the adrenals is autoimmunity in 90% of the cases. So all I care about is that autoimmunity. Just so you know, tuberculosis and other infiltrates, HIV, things like that can cause primary adrenal insufficiency. We're going to keep it nice and simple, and it's just the autoimmune mediated failure of the adrenals. Okay. The last line I just added, I think 2 or 3 semesters ago. I just think it's so cool. So most will lose 90% of cell function in both adrenals to have clinical manifestations. How cool is that? So that tells me it's a gradual process usually. Usually we'll talk about when it can be sudden. How cool are the adrenals? They can manage up until 90% is damaged. So anyway, primary adrenal insufficiency. They are people with absence, should be not news to you, but they a lot of times will have other autoimmune disorders or other endocrine disorders as well, right? Hashimoto's is one of the ones we talked about. We'll talk about type 1. What's vitiligo? Yeah, you lose the melanin in your skin. And so I have a picture of a primary adrenal insufficiency patient with that, celiac disease, alopecia, and things. Okay, so don't memorize that list, just the idea, right? The concept is important. Okay, so we're jumping right into presentation. So usually it presents gradually, or it can be sudden. Okay, so which one is sick? Sick, not sick? Who do you think? Sudden presentation? Yeah, it's gonna be it's in the name, right? Acute adrenal crisis, like that is scary, right? So they have no cortisol, they're gonna present very sick. So we'll go into what that looks like. But usually, thankfully, it's gradual, right? Months to years. So just like with Cushing's, we don't always catch it early. And a lot of that time, the reason for that is not because you guys aren't good clinicians, it's because it's non-specific, right? They're tired, like everybody. Maybe some weakness, some weight, they're not as hungry, so you might think it's a GI thing. But a lot of times people might ignore this and just keep pushing through life and not come and see them. Or you're working them up for their thyroid, their thyroid's normal, so you're like, get more sleep, exercise, eat healthy, right? Okay. Here's kind of a full breakdown of signs and symptoms. So we'll dive in a little bit more. So weakness and fatigue. Anorexia and weight loss just kind of go together. Orthostatic hypotension, right? So we've been talking about hypertension a lot with acromegaly, Cushing's, but this is hypotension, right? So those vitals, pay attention to those vitals in that case. Positional lightheadedness kind of overlaps with that orthostatic hypotension. Some of these patients will crave salt. Hyperpigmentation is a classic thing for primary adrenal insufficiency. So again, if my cortisol is in the dumps, say cortisol is low, what does ACTH do? It increases, right? It's trying to say, hey, adrenals work, we need cortisol, but the adrenals are failed, right? This autoimmune mediated condition the adrenals aren't able to produce really any cortisol or very little. And so that ACTH is constantly high, and that's that cross-reactive reaction, whereas if ACTH is super high in some situations, it can cause an increase of MSH, and then they get excess melanin. So it can vary to all over hyperpigmentation or a little less obvious. So you want to check like their freckles, check their scars, check like lines like in the axial folds, under the breasts, in the groin, and then in the mouth. You look in the mouth and you'll see it on their tongues or gingiva. The probably most classic one is the hands. You'll see it on like the wrinkles of their hands as well. So, nausea, vomiting, and abdominal pain. Again, non-specific. You think GI stuff, right? In an acute adrenal crisis, a lot of times you think it's an acute abdomen. Vitiligo. So you can have hyperpigmentation, and 2% of people also lose melanin. So what is like that? That's interesting, right? 40% of people with primary adrenal insufficiency were misdiagnosed and told because they presented with anxiety, depression, and mood symptoms, right? Again, maybe not the clinician's fault, but over time you have to get that whole clinical picture. Especially because depression can often overlaps with fatigue, not loss of interest in eating, right? So you can see why it can be such a tricky thing. Joint pains, muscle pains, scant pubic and axillary hair. That's because so as the cortisol decreases, those androgens also decrease from the adrenals, and so they can present with like loss of hair, irregular cycles or no cycles, and then metabolic acidosis. Okay. So I say that it is delayed symptoms, and these are kind of non-specific. So remember, just have this foot stop with ClinCore and all the things. Remember how important a physical exam is. So a good history with your view systems to get all this stuff. And when you're like listening to your patient's heart and lungs, I'm back here listening to their lungs. I'm looking at their skin. I'm looking for any kind of skin changes on their neck, looking for moles. Men, especially older men like that work outside, have all sorts of fun skin lesions that they don't see because it's behind them. They're not paying attention. So you're looking. You do in a wellness, even if they're not coming in for abdominal pain. You inspect the abdomen, right? You're looking for scarring. The worst hernia I ever saw was a guy who came in for a wellness. He was Army, I don't know if he's Green Beret, but some special forces guy. And he had this purple umbilical hernia, and he's like, yeah, that's fine. It's been there for months. Like, I wouldn't have known if I didn't just quick inspect, right? So inspection is really important, and you could potentially, looking in the mouth, you might catch the hyperpigmentation and things like that. So I do love telemedicine, but something about that physical exam is really helpful. Okay, so here's the cross-reacting hypothalamic pituitary axis, right? So that axis ACTH in this situation can cause the hyperpigmentation. So this is a patient with vitiligo and hyperpigmentation. Interesting, right? This woman shows that she has more of that generalized hyperpigmentation, but just looking at her, you might not know. Like, if you've never seen her before, you might miss, like, that maybe she doesn't go to, maybe she gets the self-tanner or the tanning beds or something. But again, probably people who live with her would notice that maybe that's not normal. But it is, do you see it's like darker? It definitely stands out in these creases. And then the hands are a good way to look. You're looking at the creases. The dorsal side of the hand, that is like, that's tanner or, again, hyperpigmentation, right? So this is a picture of a darker pigmented patient, skin patient. So again, you're going to look at the hands. They're darker, the toes, and then looking at her tongue and her gums, right? So that can help as well. So this is a 54-year-old female. She comes in complaining of nausea, vomiting, and abdominal pain, and she's tired. Oh, you're going to go straight to Addison's? Probably not, right? We're going to do a physical exam. We're going to get a good history. But do you think she's hyperpigmented? I don't know. We haven't seen her before. She's definitely thin. So with her, you do your physical exam. You notice maybe hyperpigmentation all over. You're going to do the labs. You're going to learn about all of that stuff, and you eventually catch it. And this is what she looks like after treatment. You give her some cortisol, and she's like a totally different looking person, right? But again, you can see how it's hard. This gentleman, okay, so he is an acute presentation. So he's 54, and he comes into the ER with confusion and vomiting. 3 months earlier, his primary care diagnosed him with stage 4 chronic kidney disease. You did vitals on him. What do you think his blood pressure is, high or low? It's going to be low because we're in the Addison session, right? Yeah, so this is him 3 months ago when he was diagnosed with chronic kidney disease. The second is how he's presenting in the ER. Okay, remember, the ER isn't going to know what he looked like back then. They're just seeing him there, okay? So they get his blood pressure, and it's 90/70, and a 54-year-old male. Okay, and his pulse is 107, so a little tacky. He's hypotensive. His abdomen exam, it shows tenderness. They get labs. His glucose is low, at 40. Right, so you might be distracted by that. His sodium is low. His potassium's a little bit high. Through a history in the ER, he reports the weight loss, which you definitely see in the picture. So 10 kilogram weight loss, and then he says, my skin is progressively getting darker. So they get some labs, which you'll learn. They look in his mouth, and they see the hyperpigmentation in his gingiva and on his tongue. And then they figure out that he has Addison's disease, right? So this is an acute presentation, and this is him after treatment on the 3rd. Okay. So the labs. I think you'll like the labs here because they kind of make sense. So again, we know cortisol and ACTH are this diurnal, so we expect the labs to be highest in the morning. So knowing that, we're going to do our labs in the morning. And if we have a low cortisol, less than 3 micrograms, then we're suspicious for adrenal insufficiency. Okay, so that's telling me just the cortisol alone tells me that there's insufficiency. Then we also get a morning ACTH at the same time. So cortisol and a morning ACTH, and ACTH is elevated. Does that all make sense to you? Right? The primary problem is the adrenals are failing, pituitary is working fine. That's why cortisol is low, but ACTH is high. Okay, correlates with the hyperpigmentation. That's what I said in there. So it's a primary organ dysfunction. We're going to confirm with this really fun test that you guys are going to hate. No, but you're going to learn it. But it'll be fine that this cosinotropin test will help confirm for sure that this person has adrenal insufficiency. Now, when you get labs on these patients, just like the gentleman here, his labs were all over the place. Granted, he's acutely ill, but it's really common for them to have like hyponatremia, hypoglycemia, anemia, and things like that. Obviously, it's going to be more severe electrolyte changes in that acute setting, but you might see some mild changes in primary care too. Okay. There's a summary slide coming too, but we're getting there. Okay, so we have our initial labs. ACTH is high, morning cortisol is low. I'm thinking primary adrenal insufficiency from my physical exam, history, and my lab. So I need to confirm it with the fun new Endo lab. So cosinotropin is synthetic ACTH. Okay, so this is something that is not done. It's done in a hospital setting, not done at home like dexamethasone. Super easy, right? This one is done. In a hospital setting too. So they're going to inject the patient with synthetic ACTH or cosinotropin, and then see what happens to cortisol after you give it to them, right? So in a normal person, cortisol levels go up, right? We're giving them synthetic ACTH, cortisol should go up. In a patient with primary adrenal insufficiency, primary adrenal is the problem, right? The adrenals are the problem. Cortisol stays low, right? You can give them all the ACTH in the world and nothing is going to happen because to the cortisol because the adrenals are failing. Okay, that's the introduction to primary adrenal insufficiency. We're going to talk about secondary and then we'll talk about treatment together. All right, so just in the name, where's secondary? Where's the problem? Most likely. Yeah, in the pituitary. There's one exception, and the exception, of course, is the most common cause. This will make sense. So, the most common cause is persistent pituitary suppression after discontinuing exogenous corticosteroids. So, you have a patient who's on steroids. Maybe they were given steroids for asthma and it wasn't a taper. So they're on high dose steroids and then they just stop. That's what this is the most common. So if I'm on chronic steroids and I realize my provider's like, you can't be on those, you need to stop it, right? So here I am right here. Here's my months on the x-axis and then our concentration on the y. So day 0, I stop my high dose cortisol, right? I stop. And we'd expect the HPA axis just to turn on, right? It doesn't, right? So you've been on steroids for a long time. So my ACTH, and my pituitary, my adrenals, they didn't have to work, right? Because I'm getting exogenous steroids. I drop that. Oh, shoot. ACTH needs to kick into gear and turn on my adrenals. But they're napping. They're sleeping. So it's gradual. So ACTH gradually, we're not in normal range until like 3.5 months. So ACTH gradually gets into this normal realm. Well, cortisol follows ACTH, it happens even slower, right? The adrenals and the pituitary were kind of just chilling. And then you immediately pull that steroids and it takes them a while to work, okay? So that's why this patient will present with adrenal insufficiency. Technically, the pituitary works, the adrenals work, they just haven't been suppressed. Does that make sense? Do you talk about that in farm at all? This is a big thing, and this happens a lot for various reasons. So again, the most common cause of secondary adrenal insufficiency. Other etiologies, these make sense, right? Here's our pituitary problems, right? A tumor, some kind of trauma, failure of the pituitary. That part you guys got right away. Okay. We're going to come back to this a few times, and if you don't get it, come and see me. Talk to me. All right, signs and symptoms. Are they the same as primary? Because ultimately they both have low cortisol, right? So they're going to have anorexia, fatigue, all of that stuff, except for there's no hyperpigmentation, right? Because it's not, the ACTH isn't high in these patients because there's a pituitary problem, or because they've been taking steroids, so the ACTH isn't high. With the person who's taking steroids, it takes a while for that ACTH to get back up. So instead, they have power. So that's like very light skinned, or even they're called alabaster skin. So they'll have pale skin, alabaster skin. So that's one giveaway as far as clinical presentation. Obviously, they also another dead giveaway would be that I tell you that they have chronic steroid use, right? And then they stopped. But again, luckily it looks different than our primary. Labs are going to be the exact same labs. Sweet, I like that. Morning cortisol is low, makes sense. And then the morning ACTH is also low, right? Because it's a pituitary problem, or the HPA axis was suppressed because of the chronic steroid use. Okay. Now, with these patients, typically they don't have electrolyte abnormalities like primary does. If it's a pituitary problem, it should make sense that they might have other hormone issues, right? Their TSH might be low. IGF-1 might be low, right? They might have anterior hypopituitarism. So, okay, we're back to the cosinotropin, right? I have low cortisol. I have a patient with fatigue. Maybe they have a history of pituitary surgery or something, and they have fatigue and they have paleness, hypotensive. They have non-specific abdominal signs. They have alabaster skin. I do the labs. The cortisol is low. The ACTH is low. Then we do the cosinotropins. We send them in the clinic, and they get in the hospital, and they do the cosinotropin. We give them synthetic ACTH, right? So, and measure the cortisol after. I know what normal people do, but in secondary, cosinotropin, it's going to stay low. Okay, let's think about this for a second. So, let's go with just the simple, you have a pituitary, the problem is pituitary, okay? And I give them ACTH. Should the adrenals just turn on? But it's just there, it's not that fast. So initial diagnosis, it's going to be low. Maybe 6 months from now, it might be high or normal, but it just takes a while, okay? Same with that exogenous, the patient who's taking steroids, right? They come in a few weeks after they stop steroids, so they're right here. You give them ACTH, but the adrenals haven't been working. They haven't been working at all, so it's not immediate. But if we do cosinotropin and we manage them or watch them for a long period of time and check it later, we might have normal levels. I won't trick you on the test. It will be more straightforward, I promise. Okay, but again, the concept is it's low initially because of the HPA axis is suppressed. Okay, so we see how they're different. Let's look at them side by side. So do all the animations together. Primary, hyperpigmentation. Lab electrolytes are off. ACTH is high. The problem is in the adrenals. Secondary, no hyperpigmentation, no electrolyte issues, and they have low ACTH. It'll be low on the test. Both will have low morning cortisol, and both will have cosinotropin. So hey, just like with Cushing's, the ACTH points me in the right direction. But benefit with adrenal insufficiency, the physical exam helps me too, right? Cushing's, it does the exam is the exact same. But in this one, we have exam differences and the ACTH is the money lab, right? It's an annoying lab, finicky, but it helps me figure out what's going on, where the problem is. Again, we give someone normally ACTH. we accept the cortisol to go up. Primary, it stays low because it's an autoimmune adrenal disruption. Secondary, it stays no due to adrenal suppression, right? It takes a while to wake up. It's like 3 times I talked about it. Hopefully, okay. Imaging should hopefully make sense, right? So again, if I have this, so if I have a primary adrenal insufficiency, hyperpigmentation, ACTH is high, I'm going to look at the adrenals. I'm going to do a CT scan and look, and I'll see these small adrenals. Secondary, we're going to look at their meds, maybe taper those off, and then we'll look at the pituitary. So imaging is pretty straightforward. Now we got to treat. So in both of these, the underlying issue is what? Not enough cortisol, right? So it makes sense we're going to give these people cortisol. We need to replace the glucocorticoids to this physiologic level, just like thyroid, right? We're trying to get them in that euthyroid state with levothyroxine. We're going to do the same thing with these patients. So primary adrenal insufficiency, autoimmune triggered failure of the adrenals, right? It's primary. We're going to give them hydrocortisone or prednisone. Current says you do the doses like a little bit, you'll have a different dose at night versus morning. So you might have a higher dose in the morning and a lower dose at night to recreate that diurnal. That's just more FYI. I wouldn't ask you that specifically, but that should make sense. We'll talk about stress dosing in just a minute. Now, with primary adrenal insufficiency, we have a failure, an autoimmune failure of the adrenals, right? So they also will need mineralocorticoid aldosterone replacement too. So you have to also consider that. And then DHEA. This is the only time I don't have FYI by DHEA. So patients with adrenal insufficiency, we give them DHA, and it's kind of like a subjective-y thing, but their overall quality of life, they feel better. So it just helps them feel generally more energy and things like that. So also it helps with muscle mass, reduces osteoporosis. So again, all those hormones that the adrenals are supposed to produce, we're supplementing with that. Okay? What's the one I care about the most about? It's the no crap. What do I care about the most? Out of all of these, steroids, glucocorticoids, all day long, right? That's like, yes, I do want to have enough aldosterone. Yes, DHA helps with all of the things too. So technically, they're going to get all three, but steroids are absolutely the most important. Okay, so stress dosing. So we know in normal people, all of you, when you take an IPAP test, your cortisol probably goes up, and that's okay, right? When you have an infection, cortisol goes up. Exercise, all of these normal physiologic causes of cortisol. Well, you have a patient whose adrenals don't work, so we're giving them glucocorticoids. So does it make sense when they're sick that they should increase their dose, right? They need a little bit more cortisol when they have pneumonia, when they have a UTI. For some people, if they have like the shingles vaccine, right? So that's a live vaccine in your immune system, so things like that, okay? Does that make sense? Maybe like a dental procedure. Okay, so those are sick day rules. So you're going to double or triple your glucocorticoids for a mild to moderate stressor. Okay. So you're going to, I say auto refills, so you're going to have steroids, you're going to have you're going to want them to run out, essentially. So you're going to prescribe them extra for those factors. Severe illness, though, like I have trauma, a car accident, unexpected surgery, big stressors to the body, then we're going to need IV or hydrocortisone, followed by an infusion. Does that make sense? Right? We're going to monitor them a little bit more. This is that little URI, UTI, we can manage that by doubling, versus significant severe illness, we need to do IV. As their cold gets better, we go back to normal. As they recover from their traumatic event, we do the IV hydrocortisone initially, and then we do an infusion, but then we gradually get them back to what? To oral steroids, okay? So an emergency kit, just like our diabetics, We'll have emergency kits, and we'll learn about that. All of patients with adrenal insufficiencies, primary adrenal insufficiency, will have a kit. Actually, both will. And it's 100 milligrams of hydrocortisone, and it's a vial, and it's an IM dose. Okay, so you're educating the patient and family members of this. And so this is when we're worried about like adrenal crisis. So we're going to educate them of what, when your cortisol is really taking, you're going to have this emergency kit. And this patient is Amber, and if you read, it's kind of dark, but I like it. It says, adrenal insufficiency, steroid dependent, exclamation points, times like 5. Needle and vial in purse, give drugs or watch die. Right? We need steroids. So I have that in there because they hit over and over again. They need steroids right away in these emergency situations. Okay, so that's for primary. Secondary is overall the same, right? We're going to give them glucocorticoids if there's a pituitary problem, right? Because pituitary, it's a problem, it's not able to release ACTH to tell the adrenals to wake up and do what they're supposed to. Typically, those patients only need glucocorticoids, okay? And that's because aldosterone and the androgens and all of that are also driven by other hormones, not just ACTH. I don't have it on the slide, I'll just tell you it. It's not on the slide, I'm not going to test you on it, but for those patients who are on glucocorticoids, we're still gonna, we don't just stop them, right? They already did, they caused the problem, right? They caused secondary adrenal insufficiency by stopping their meds abruptly. So we need to taper them back up on steroids and then taper them off. So we can, and that taper takes like 6 to 12 months for some people. They don't usually need, okay. Treat the underlying pituitary disorder, and then they also have their kit. Okay. Questions on primary or secondary adrenal insufficiency? Okay, we're going to go into this acute adrenal insufficiency or adrenal crisis. This, remember, your absence patients some of them might present like this, like the gentleman with a history of chronic kidney disease. He came into the ER, and that's how they diagnosed him. But it's an immediate threat to life, right? Give me drugs or watch me die. So it could be a person that we know has Addison's and they come in the ER immediately. I want labs, but you're immediately going to treat them with steroids, right? If they have a history of Addison's disease. But again, sometimes they'll just show up without knowing what's going on. Magnified symptoms, right? So very acute GI. So nausea, vomiting, fever. Gets a lot of times in your steroids might be in the protocols in the ER for other disorders that present the same. Okay. Again, known insufficiency or initial presentation. Precipitating factors. This should make sense. It's kind of like your mixed edema crisis or your thyroid storm, right? Significant stress, trauma, surgery, withdrawal glucocorticoid therapy. Yep. Bilateral adrenalectomy. So if we're removing their adrenals, I really hope they're under care. But if they're had both adrenals removed and they don't have, maybe they're on steroid supplementation or they're not taking it right. Pituitary apoplexy. Remember that? That was a long time ago. So that's that hemorrhage or that infarction within a pre-existing adenoma. And they present in a triad of 3 things. The headache, vision changes, all of that. So that could be, that's when we give steroids right away. IV, etomidate, you could just put FYI by that one. It's a short-acting anesthesia, and it blocks the conversion of cholesterol to cortisol, and so that could potentially cause adrenal crisis in these patients. But that's a little in the weeds, I think. So again, extreme weakness, significant hypotension, fever, nausea, vomiting, dehydrated, hypoglycemic. These guys are definitely sick. They're confused. They have delirium, right? That gentleman's blood pressure was super low. His glucose was 40. His sodium was, I forget what it was. It was crazy low. Okay, so we're in the ER. Someone comes in. Maybe they don't have a history of primary adrenal insufficiency. They don't have a history of steroids or use or anything like that, but we're suspected based on this. We're gonna do labs, but do not wait for that low cortisol to start medicine. Okay, these patients they're gonna give cortisol. So sometimes in the ER we might give hydrocortisone to somebody who doesn't have adrenal crisis. Usually that's okay. All right. So again, IV 100 milligrams of cortisol immediately. And that just is like when I say that sometimes we do that, it's just like there's these things called emergency protocols. So based on how someone presents, they might get this and this and this. But yeah, it'll be pretty clear on the test. I hope. But again, do we wait for labs? No. Do we wait for cosinotropin tests? No. We're going to give them steroids immediately. Labs are important. Ideally, before we give them the steroid, we're not going to delay treatment. And then again, it's hydrocortisone immediately, IV, and then likely they're going to be monitored for a while. We're giving them fluids because they're dehydrated, right? They have nausea, vomiting, they may have a fever, and then potentially some broad spectrum antibiotics. What do you think I care about most? Right? That's steroids. So, prognosis, usually do well, but they have to be really compliant with their meds, right? Understand the stress dosing and things like that. For the generalized fatigue and weakness, DHEAS will help with that, right? That's that third medication that helps. They might have an increased risk for malignancy, infection, cardiovascular disease, but it's mild. And then obviously, acute adrenal crisis is the scary. Recognition is key. If we don't recognize it, we don't give them the steroids, they don't do well. Okay. Totally different topic that we'll wrap it up with is disorders of mineralocorticoids, specifically aldosterone. So, sorry, cortisol, talked about you enough, we're going to talk about aldosterone. So, kidney stuff, and yay, everybody's favorite, the renin, angiotensin, aldosterone system, or the RAS. Awareness, okay? This is just to like wipe the cobwebs off of learning this, like AP maybe, or pathology? I don't know, I think in GU they'll dive into it more. Or maybe in cards he went into it too. But essentially it starts with renin, and renin is released due to like a drop in renal perfusion. So whatever the cause is, renal perfusion issue. But renin goes up. When renin goes up, angiotensin is released, angiotensin 2. And angiotensin does all of its thing. It impacts even that ADH is on there, down at the bottom, right? But what I care about in this one is angiotensin 2 activates aldosterone secretion. So then it's all related, okay? And then we get homeostasis, and it turns off that renin. Just general overview, you can read it if you want to. But again, the goal of aldosterone and this whole thing is to increase blood volume. So aldosterone, how it helps is it reabsorbs sodium, water comes with it, and it excretes potassium, okay? So pulling on to the sodium, water comes, excrete potassium, like ADH. Okay. Again, once that's done, we have homeostasis. You have the negative feedback loop, less renin, which down the road will be less aldosterone. Just an overview of the hormone itself, secreted by the adrenal cortex, and again to increase blood volume. So if we have higher aldosterone, we'll have higher sodium. Holds on to that and takes out potassium. Here's another feedback loop. It's pretty simple. Just know that, again, the primary driver for aldosterone is the RAS, but ACTH also helps. Okay. What do you think? So renin drives it, and then the abnormality we're going to talk about is primary hyperaldosteronism. So what does that tell me? Where's it from? Primary, yeah, the adrenals, right? If aldosterone is high, primary hyperaldosteronism, what do you think renin? If we check a renin lab, is it going to be low or high? It's low, right? Because it's the negative feedback loop, right? So again, if you get stuck, you can go back to your feedback loops. All right, so here's the one condition we're going to talk about. Hyperaldosteronism. So this is so you guys are learning about essential hypertension, right? That's the CARDS test on Friday. So this is the most common endocrine cause of secondary hypertension, okay? This is a patient who is resistant to medication, or they're really young, or they're really old, and then they get a new diagnosis of hypertension. You have to throw a lot of meds at these patients, and they're not getting better, okay? 5 to 10% of hypertensive patients have this. And you're going to think one clue that you think you have a person with hypertension and their potassium is low, and they're not really controlled well, you're going to have hyperaldosterone in the back of your mind, right? Because when aldosterone is released, it pulls out sodium and excretes the potassium, and that's why you can see hypokalemia in some of these patients. Why do we care and we want to make sure we catch this? Is because these patients, everyone with hypertension has a risk for cardiovascular disease, but these patients have a more prevalent risk for all the cardiac events, right? So we want to make sure we treat them. When we figure out the underlying cause, that means we have to change their meds and things like that. Okay, so these people just get missed. They think that we think, oh, we just have essential hypertension. Oh, you're not controlled. Let me throw another med on it. Let me throw another med on it. Oh, maybe their potassium is normal, right? Only 37-ish, 40-ish% of people have low potassium. All right, so let's go to what the problem is. Excess aldosterone, it's in the name, produced by the adrenal gland, also primary hyperaldosteronism, renin independent. So that means there's the RAS. Usually in a normal person, and all of you, renin is triggering the release of aldosterone, right, and ACTH. But it's independent of that, right? There's something in the adrenal glands, an adenoma or hyperplasia, that's causing that excess aldosterone, okay? So independent of your RAS feedback loop. So primary etiologies is bilateral adrenal hyperplasia, right? The gland gets bigger and more active, and aldosterone, in this case, is getting released. Versus an adenoma. You have a aldosterone-producing adenoma that kicks out excess aldosterone. It's kind of a trend here with these adenomas, right? These hyper excess hormone secreting guys. Okay, so how do they present? Hypertension, right? Moderate hypertension, refractory. It's not getting better. Hypokalemia. So when we have someone with hypertension, we do labs, right? Especially at onset of diagnosis, we're doing a CBC, a CMP, doing a UA, doing an EKG, I'm doing a UA, right? So we do all these labs at the beginning, but then we also, with someone with hypertension, we have to check kidney function every year, right? So we do a CMP, and man, their potassium is incidentally low. They feel fine, usually. Why is this person's potassium? It was low last year. Now it's low again, and they're not controlled. Ooh, maybe there's an underlying secondary cause of their hypertension. Okay. Unfortunately, so when I was in school, you only thought hyperaldosteronism when potassium was low. That was it. But unfortunately, what we've learned over years is that only about 40% of people will have low potassium. So then that means like the vast majority, or over half of these people, their potassium levels are fine, but their aldosterone's high, and that's what's causing their hypertension. So again, they might have other symptoms, and then again, we think that refractory hypertensive patient, young patient who's not getting better with meds. They have muscle weakness, cramps, fatigue, polyuria, polydipsia. That's all associated usually with, these symptoms are associated with the hypokalemia. Okay? The big thing in here is hypertension. So, we treat, thankfully, majority of your patients, I don't know if it's 90% still or what it is, but the vast majority of your patients with high blood pressure or hypertension, it's essential, right? But then there's those secondary causes, like we learned about coarctation and all the other causes that you learn in CARDS. But for endo, this is the most common. We're thinking about it when you have a patient who has really high blood pressure, You have resistant hypertension, so they have 3 conventional meds and it's not controlled, or 4. The only way you get them controlled is 4+ meds. Hypokalemia, right? We understand why that happens. Low plasma renin activity. I'll tell you what that lab is in just a minute. Family history of early onset hypertension. You have a family history of primary aldosteronism, so you think that family history. Or you have an adrenal adenoma incidentally found. So you have someone with hypertension and they get a CT for some reason. Oh, they have an adrenal adenoma. You have to work that up. And you find out that they have high aldosterone levels. I guess they understand this, but I'd be kind of clear on the test if I have a hyperaldosteronism patient. But I have that just to help you get there. All right, so labs. So we're going to do a CMP, right? Because that's going to show me my electrolytes. We're going to do something called a plasma renin activity that tells me what renin is doing in the body. Okay, aldosterone, we're going to check that. 24-hour urine aldosterone helps with confirmation. So what do you guys expect the potassium to be in a classic endocrine patient on a test? What's potassium going to be? It's going to be low, because I'm going to give you those classic patients, right? What do you think the aldosterone's going to be? It's going to be high, right? What about this? But plasma renin tells me what renin's doing. Is renin going to be low or high?
Low.
Low, exactly. Great. You know that from that RAS diagram, from feedback loops, right? Because again, this is renin independent. It's inappropriate secretion, unregulated secretion of aldosterone causing the problem, right? So then we expect renin to be low based on that, aldosterone to be high, and potentially the potassium will be low. If you did a 24-hour urine aldosterone, it's going to be high. Okay. What kind of imaging would we do? Yeah, I'm going to do CT, looking at the adrenals. You can do an MRI too, and then they would point. The radiologist, the lovely arrow sign would tell you have an adenoma. Okay, so now we go into treatment. Okay, so we have this patient with hyperaldosteronism causing hypertension. I have to treat the hypertension, right? And so luckily there is good medication and good options for these patients. So I told you the two causes could be an adenoma or bilateral adrenal hyperplasia. So for the bilateral adrenal hyperplasia, we're going to really rely on medications, potassium-sparing diuretic, but specifically spironolactone, right? Spironolactone will decrease the amount of aldosterone released in the body, right? Antagonizes aldosterone, and it can help treat blood pressure too, right? So it's the most effective. Spironolactone is, we're talking about it a lot next block, but spironolactone is the best medication that these guys will be on. Maybe they're still on their lisinopril or their ARB or whatever, but you need to add spironolactone, and that can make a huge difference for these patients. Epilurone is another potassium-sparing diuretic. It just costs a lot of money. But if you have a pregnant patient or a male patient, if you can get this approved, it's hard to get it approved because it's expensive, you can cause it. And the reason why males sometimes don't like spironolactone, because it has an anti-androgen activity, so they might get breast tenderness, gynecomastia, reduced libido from the spironolactone. So you kind of let them know this could happen, but also we need to make sure we treat hypertension. And not all men will have that issue. But there you go. There's another one on here that's not as expensive as Epilurone, but Current didn't have it, so I just didn't throw more meds at you. Now, if you have an adrenal adenoma and they're 37-year-old male and all they have is this hypertension that we finally catch that it's hyperaldosterone triggered, then you could have surgery to remove the adenoma or potentially remove that adrenal. Okay? You have to manage their blood pressure. But yeah, so surgery for the adenoma, it kind of mimics what we've learned with ACTH-independent cortisol, right? For the bilateral, in both cases for bilateral adrenal hyperplasia, whether whether it's causing excess cortisol or excess aldosterone, treat with meds. If it's an adenoma, you go for surgery. All right, so we can stop there. The last one is congenital adrenal hyperplasia. I have 8 minutes. I could probably get through. What do you guys want to do? We won't get to the clinical cases, or do you guys need? Are you done? You guys do it? Okay. Here we go. All right. So these conditions are really, really cool, and we'll talk about them more next block. But remember, androgens are also released. We're going to talk about PCOS and that stuff later. Anytime you have excess androgens, you obviously want to look at the medications because medications can cause excess androgens and stuff. And again, we're going to dive really deep into this with the next block. So the only condition we're going to talk about in this one is congenital adrenal hyperplasia. So congenital, so it's something they were born with, adrenal hyperplasia. Okay, so this, just like, remember the babies with creatinism where they had a failure of thyroid to develop congenitally, and we do the HEAL test to check for thyroid. We also check for adrenal hyperplasia in the United States for babies who do get that the HEAL test. So it's a newborn screening, just like the thyroid. So essentially what happens with this is it's a lack of enzyme. So the enzyme is deficient or defective. So if there's no enzyme, then essentially we don't get cortisol synthesis. Okay? And there's a lot of different enzymes, but the most common is all I'm going to talk about, and that's 21-hydroxylase. It's an enzyme required to get cortisol, and it's deficient. Okay? So let's follow this. So most common deficiency is 21-hydroxylase. And I can't get cortisol, so if cortisol is down, ACTH goes up. ACTH is released telling the adrenals to work, so then that's what causes the adrenal hyperplasia. Okay, just like goiters in a hypothyroid patient, right? It's that TSH consistently released that causes that hyperplasia. And then what happens too is you have, from this, I'll show you the next picture, we have an excess of this hormone, 17-hydroxyprogesterone. It's a precursor. It'll make sense in just a minute. We have excess of that, and then that's what causes excess androgens. All right, so let's look at this lovely picture. Or diagram. So we have a failure. This is failing, right? This enzyme isn't there. You can't get to cortisol. So does it make sense? So ACTH is like, hey, I need more cortisol, and that produced, does that make sense why 17-hydroxyprogesterone is in excess? It builds up. And over time, it got to do something. It can't go down this pathway, so it goes this pathway and we get more androgens. Okay? Deficient, build up. Here we go. This is missing. If this is missing, we're going to check this lab and this will be high. So they're 17-year-old, they're never going to get to 21. I don't know, that's how I remember it. So if you're like, yeah, so you could memorize that or you could think, again, I'm always, when you're 17, you just want to get older, you just want to be able to have that beer, right? Like your older sister or brother, but you don't, you're just stuck at 17. Never make 21. Okay. That's hopefully helpful. There's 2 types of classic and non-classic. Classic is very severe. They're completely deficient of 21-hydroxylase. So they have, when they're born, they have no cortisol, and so they don't do very well. And then there's a milder version where they have some enzyme, just enough enzyme to do well until puberty. And then they'll present at puberty. Okay. So here's that classic. So again, adds to the total loss of the cortisol, so they might not make it. Or if they do, they can have ambiguous genitalia if they're females. Do you know what the word virilized means? So it's like excess male hormones, so then females present with like male pattern secondary sexual characteristics and stuff. So it's due to that excess androgens, that excess testosterone. Okay. But again, and so the pictures are just that like ambiguous genitalia. quite sure what's going on, and that's again, it's because there's the deficient 21, and so we have excess androgens causing this issue. Now, the non-classic is more common, and what I need you to know. Okay, so it mimics PCOS, which we haven't gone through that, but they're typically it can happen before puberty. We'll talk about during puberty. They're going to have excess androgens, right? So a normal patient, we have a surge of androgens during puberty, right? And so these people will have hirsutism, acne, hypertension, irregular cycles, or maybe they don't have a first period, infertility, that stuff. And so I think, and I caught this when I was doing the root, precocious puberty isn't on your slides, so I can't test you on that, but precocious puberty, you could write that in, just it helps with the case that we'll do later. But what is that? What is that, do you think? I know you haven't had. It's like where puberty happens too early. So you have like a 6-year-old who has excess androgens and they start showing signs of puberty at like 6. So it's like early onset puberty. Okay. Again, the underlying thing is here's this excess androgens. So we're concerned about congenital adrenal hyperplasia. What lab should we check? 17-hydroxyprogesterone. Absolutely. That's going to be high because remember, get to 21, we have excess 17-hydroxyprogesterone, and that causes excess androgens, which causes precocious puberty, which causes this hypertension, hirsutism symptoms, and things like that. Okay, so that will be elevated. How do we treat it? Sure. Maybe one day I'll have you guys know this, but you don't need to know this for my class. All I need you to know for congenital adrenal hyperplasia is to identify it, so what's the most likely diagnosis? Or lab, right? Because you can do that. Or what's deficient? Okay? One of those 3 test questions will be on your test. Okay? So be able to identify this. This presents differently than all the other cases we've had, right? And be able to understand 17-hydroxyprogesterone is the lab, or what's deficient, 21-hydroxylase, okay? You don't have to treat it. I'm not going to be like, what are the signs and symptoms? It might give you a picture to go to this, and that's what you have to know, okay? Here. It's super interesting, these things, but we won't go into it. All right, so that is it for all the new topics. On 2 days, we'll go and we'll do the clinical correlations, check on learning, and we'll wrap up. We'll have plenty of time to finish the last section, which is the doula stuff and some more hypertension. I'll see you 2 days. Ooh, right on time. 9:50.